questions?
Thank you. Thank you for these wonderful lectures. I would like to start with a question for Professor Meyerle. I absolutely understand the models and the studies that need to validate the findings, but my idea was when you showed that the risk of newly onset diabetes mellitus is 5 times higher than in the general population the first year. Does this justify an intensive imaging like MRI of the pancreas in the first year? This came to my mind that this might be justified already now, apart from the surveillance program that you're proposing or studying.
I agree, and while we were writing the grant for the EU, we were really intensively discussing these aspects. And if you go back to the guidelines and more or less to all European guidelines, then probably an ultrasound might be indicated, because that would have an excellent negative predictive value if you see the pancreas and you don't see a mass. Then that might be helpful. However, if you look very closely to the data published by Suresh Chari, who did in the Olmsted County, so around the Mayo Clinic, these studies on the incidence and prevalence of new onset of pancreatic cancer in new onset diabetes, he showed that in many instances imaging was normal a year before the cancer was detected. So I'm not sure, and we don't have data at the moment, whether a more intensive imaging strategy would really reveal the cancer patient at present, and that's why we think that this prospective trial is really warranted, because the data is weak.
Thank you.
My question goes in the same direction, maybe. May it help? You have the patients who developed new onset type 2 diabetes mellitus, where you expect them to develop it because they are obese and have all the risk factors. May it help when you take the other group, the skinny patients, where you don't expect that they would develop diabetes, that they are exactly those who would benefit from the imaging and diagnostics?
The interesting thing is that exactly that has been studied by Chari as well, and they looked for the lean patient and whether they would have a higher risk of developing pancreatic cancer, and they did not. So it is not the phenotype which actually, where you can, or an overt phenotype where you could reduce the number of patients for surveillance or screening, how you would like to call that in this cohort. I found that pretty interesting, but the biology of these diabetes mellitus, it's neither a type 2 diabetes in a classical sense, nor, and that is in many instances wrongly recorded, it's not a type 3C diabetes, which is found in those patients. Somehow if the patient get operated on, the diabetes mellitus will actually disappear, and that is not only because after the Whipple's procedure the patients lose weight. That might be some aspect, but it's certainly not all of it.
I have 2 questions. One is, I would like to challenge you, Marco, on the Yashida paper, because you mentioned that from pathological analysis, they reckon that there is a long period and we would have quite a lot of time with screening. But as a matter of fact, even when we detect very small lesions, we have a very high chance of micrometastases already. So what would be the means to screen in this setting, because imaging is not going to be the case? And one question for Julia, how robust are the algorithms with respect to nutritional state, to infections and so on? So you're working in a metabolome, and of course this is prone to challenges by food, for example. So how robust is that, and what is your perception whether this could be also applicable for general screening? You put that very narrow, that I think is fine, but is there a chance to develop metabolomics for general screening in the population Patrick was so nicely elaborating on, aging population and higher incidence? Thank you.
There you raise a very interesting point, because if we go back to the population of diabetics, where we see that some of them a year later have pancreatic cancer, there the interval that we're talking about is 1 year. The persons that we are now screening, for example, in the Netherlands we have these 300 persons, the average age is about 54. And we know that in this group of persons, the cancer will arise somewhere around 60, 65. So we have still quite some years to go until we'll see the peak incidence of pancreatic cancer in these persons. So, in fact, now the interesting years start to come, because now we will see the natural development of these precursor lesions into a pancreatic cancer, because we don't know anything about this. We don't know exactly what is the timely events or what we can see on morphological imaging of pancreatic cancer. So that's a big challenge. So if your kind of indirect question is, do I think whether we can manage with just morphological imaging? To be quite honest, I think the likelihood is relatively limited, because I think we will run into problems with sensitivity and specificity. And of course, maybe what we have not said clearly, I think you can do good for persons, but you can do a lot of harm. Because what we do, if we decide that there is a lesion, that is a precursor lesion, whatever, we have to do pancreatic surgery, and still pancreatic surgery is major surgery. People die from pancreatic surgery and have substantial morbidity from surgery. And that's the delicate balance that has to be kept and weighted.
Back in the audience.
Yes, three very nice talks this morning. Thank you very much. I wanted to ask about the type 2 diabetes in a bit more detail. I'm just trying to get in my head around the biologic rationale of why a tumor, if that's picking up an early tumor, why that's causing type 2 diabetes. I mean, is it presumably these patients are not symptomatic. Presumably the tumors are not that bulky. And do you envisage that it interferes with the islet cell mass, or why actually are they getting diabetic?
Well, I can only cite the literature, but basically what we understand is it's insulin resistance. So it is a type 2 diabetes in that sense that you see an increased HOMA index, but there seem to be specific molecules like adrenomedulin, and probably there are a couple more, which signal or mediate this specific diabetes, which do not play any role in other types of diabetes. So whether that's a crosstalk between pancreatic ductal adenocarcinoma cells and islet cells and how they mediate this signal is not proven or not well studied at the moment. What we know is that if you use knockout animals for like adrenomedulin, then you see that there's no longer any diabetes, but if you have an overexpression, then they develop diabetes concomitant with pancreatic cancer.
So will your grant shed any light on this relationship?
We will try to. Actually, we will try to. And we have one part where we actually would like to characterize from the biological samples which we will collect if we get funded during the study. Yes, we would like to do that. Whether we will be successful, I cannot tell you at present.
Thank you.
But can I just answer Thomas' question, because on the robustness of a metabolite panel, I was quite amazed how robust it is. So when we started off, those were retrospective samples, so they were not collected in a very standardized way. So we couldn't even be sure whether that was fasted or non-fasted. And we still saw a very strong discrimination between the groups. Yes, there are some metabolites which are heavily influenced, and usually you probably would not pick them for your marker panel. You're not going to use 1,400 different markers. So you can pick wisely and choose wisely. However, I'm rather more frightened about, as we clearly see that the metabolite panel is not influenced by tumor burden, that you might pick up other cancers than pancreatic cancers, and that we haven't controlled for or studied at present. So it could well be that we pick up breast cancer, lung cancer, cancers with an even higher prevalence or incidence in the population and not be specific.
My short question to Patrick. Do you consider that there should be additional screening programs for these Central European countries with high prevalence of pancreatic cancer, as was shown today? And the second part, is there any upper limit of age to consider to stop the screening, even in chronic pancreatitis patients?
For the first question, yes, there is a higher risk of pancreatic cancer, or rates of pancreatic cancer in Central Eastern Europe countries, it's not huge difference compared to rates in United States and other part of in other westernized countries. Maybe it reflects different lifestyle. I'm not sure there is an impact on screening or any aspect. This is just a descriptive feature. I don't know who can answer for the...
Well, I can say something about the second part of the question. That discussion has not ended. And I think based upon the data that you showed, it shows very nicely that we get older. And maybe 20 years ago, when somebody was 70, he was almost at the end of his life cycle. But nowadays, people of 80 sometimes start a second youth. So, and sometimes they are more healthy than I am. So, you know, who am I to decide? You know, that's a very difficult discussion. I know now that our pancreatic surgeons are not afraid anymore to operate people from 80 years or older. But it's a good question. You have to put it in perspective. I don't know exactly. With regard to... the second part of your question was?
Yeah, about the stop age. Okay,
Yeah.
do that. We have also a microphone at the back. Sorry.
Thank you very much for wonderful talks and discussion. I had a question for Professor Bruno regarding the Ishida paper. One of the biggest criticisms of their model is that they calculated that the time period of progression based on a linear collection of mutations. Yeah. That is, they assume that there's a standard rate, linear rate of mutation that gets collected from start to finish. Yeah. And there have been a lot of studies that suggest that later on in the disease process, once a tumor forms, once there's metastasis, there's almost an exponential increase in the number of mutations that are collected. And that might influence the model, for example, but might also explain how many of us in the audience see these patients in our screening programs where, again, there's a CT scan in a high-risk patient that's normal. 1 year later, there's disseminated disease. I wonder if you could comment upon that.
Okay. Well, I think you're very right. This is a model that there are lots of assumptions in the model. But even if you take this whole span in time and you divide it by 2 or by 4, it's still a lot of time, at least in theory, to look at early stages of development of pancreatic cancer. We now have, already in the Netherlands, we have 300 of these cases, and we work in a worldwide consortium together with Hopkins. And we also, for example, have now more than 100 persons being operated because of a finding in the pancreatic cancer screening program. And it seems that we are doing some good in these patients. We will present this on the DDW next month. To be quite honest, we haven't come across persons in this high-risk screening program where on year -1 we see nothing, and then a year later they have kind of disseminated disease. That's not our experience. If your question would then be, what then is your experience? How exactly do these precursor lesions develop over time? We don't know yet. The thing I can say is that in the cohort that we have now with the average age of 54, not much happens. If they have an IPMN lesion, or very often they have multifocal IPMN, not much changes. Additional lesions occur, they're not getting bigger. So we have to continue following these patients to find out what happens, and if we can use these changes then to set kind of a threshold where we should do something or should have watchful waiting.
Yeah, I fully think that the screening program's justified, and we do it too. The issue is timing at those later stages. I think that's where the model really breaks down.
You're right.
Chairman? I would like to come back to the very first question Florian asked, screening of the sort of intermediate risk populations. You answered that sonography might be good, but you know well that sonography often is not well feasible because you don't have good conditions, and it's not applicable in all countries. So if we extrapolate and say, but this is a population we need to screen, MR would be the next step, right? But do you have evidence that MR is any useful, even in the high-risk population? If I'm well informed, I mean, there have been series of 200 or 300 patients, and if you do MR, you detect some cancers, but usually it's too late. So as a screening tool, even as a screening tool and being more sensitive probably than sonography, it's not useful. Is that true? So we actually, to make the point, we don't have anything for the moment?
Well, We know, for example, that MR is much more sensitive, of course, to detect cystic lesions than EUS. The question is that relevant? Is it relevant to detect a cystic lesion of 3 millimeters or something? We don't know. I think this is exactly a subject in science where we have to have patience and where we need to collect prospective material in time. This is not a research program you can finish in 3 or 4 years' time. It's already difficult, and you kind of alluded to that, to identify these high-risk persons, to kind of collect a large sample of high-risk persons and then to follow them up. With regard to selecting the person that you should screen, I firmly believe that you should not screen low-risk or average-risk persons. I believe you should not screen chronic pancreatitis. We don't in our clinic because it's already difficult to do this in a healthy pancreas, let alone in a diseased pancreas. So you can also do a lot of harm again if you over-diagnose lesions. So we don't do this in chronic pancreatitis patients. We believe that imaging is not the way to go in those persons. We have published together with the consortium in Gut an article where we believe are the true high-risk persons. We have identified those, and we kind of aim for a 10-fold increased lifetime risk. Of course, that's debatable. You have to have a threshold point somewhere, but that's what we defined. But if we cannot prove that it's going to work in this high-risk population, then for sure it's not going to work in the lower-risk populations. So I think we should first concentrate on the truly high-risk populations.
But I think that again points to the factor that we always mix up screening and surveillance.
Absolutely, yeah.
And I think in a high-risk cohort, it's surveillance.
It starts with screening, but then when they have a lesion, it's surveillance.
But if we think about in an intermediate risk cohort, we could do screening, but we will never do screening in a, say, non-risk or non-increased risk cohort, because in a normal population, I mean, we've learned from mammography and prostate-specific antigen screening that it doesn't help anybody, but it does do a lot of harm. And even if pancreatic cancer is a deadly disease, you still die from surgery. So I think we have to, we should not mix up these two terms.
Marco Bruno, maybe a last question or comment from my side. I'm a surgeon, and you had the third or fourth slide where you have summarized how to improve prognosis. I think you forgot the surgery, the timely and adequate surgery on this image. What do you think about that?
Well, I started off with my first slide to provide everybody with the proper healthcare resources, and that's what I mean. You know, we are luckily in our clinic, we have good surgical facilities, and of course that's what you need. But from a technical point of view, the surgeons have tried a lot and everything, you know, with regard to lymph node dissections. From a technical perspective, surgery cannot be improved that much. Of course, you need to provide surgery in a timely manner to people that need surgery. But from a technical perspective, there's not much to gain. I do believe that from neoadjuvant therapy and immunotherapy, I think, you know, it will take time, but we'll see. There will be progress there. And it's not just screening that, it's the whole, you know, the whole palette of things. We have to look at various ways to try to decrease the mortality, and screening is just one. And again, I hope I emphasize in my talk, we are just at the beginning of learning whether we can do something good.
Okay, with the surgical stuff, we are getting into the next session, I think.
Just final thing, we can multiply hazard ratio, red meat, smoking, and coffee. Does it give added value or lower value for?
Okay, coffee is not a risk factor. It used to be thought to be a risk factor. Thank you for that. No, you cannot just multiply all that because many of the variables are correlated. Smokers also drink and also eat red meats, etc. Maybe one measure I didn't present in my given presentation is primary prevention. I just put one slide and show the recommendation. What we know for pancreatic cancer is that the combination of smoking, EV alcohol, abnormal body weight, lack of physical activity, all these aspects that you can prevent are responsible for 30% of pancreatic cancer. So I agree with Dr. Bruno, it will be very difficult to tell a smoker to stop smoking, to take a drinker, to abstain drinking. It's very difficult. We will never reach a zero percent in that group of percent. But these factors, these avoidable factors are responsible for 30% of pancreatic cancer.
But we can still run for coffee right now.
Yep, definitely.
So, and this will sum up our session. Thank you.
Thank you.